I have some disclosures to make. They're listed on this slide. And I will talk about some principles of embryo implantation, causes of unexplained implantation failure that, for purposes of today's lecture, mostly relate to endometriosis, and discuss some exciting animal model experiments that we're doing that I think we can take on to human trials in the near future, and some future directions that pertain. So the endometrium, as you all know, is a dynamic tissue that is hormone responsive. It starts after menses as a low, thin lining, and under the influence of estrogen grows up till ovulation, when progesterone transforms this endometrium into a secretory structure. The endometrium has to go through these changes in response to progesterone to become receptive. And as I will talk later in this talk about progesterone resistance, when you don't have good response to progesterone, these normal changes that allow the embryo to attach, as shown in this section here, will result in infertility or miscarriage. The bottom slide is also important as it depicts decidualization, which is critical for normal progesterone action and also normal fertility. Well, as we all know, the implantation process is driven primarily by the ovary. And the ovary orchestrates all of these estrogen and progesterone changes. It also releases the egg that has to traverse the fallopian tube. And the timing is such that when the embryo is ready to implant, hopefully the endometrium is ready to accept it. We also, when not talking about IVF and talking about natural cycles, we recognize that the corpus luteum itself has a optimal window during which it can be rescued, and we can talk about that if people have questions. Let's see. So for any embryo that is available, there's different fates that can occur. Maybe 60% of pregnancies are preclinical losses. This slide was adapted from Macklin's paper in 2002. And many embryos simply fail to attach, and others are lost before they're clinically apparent. Once pregnancy is established, we also have a clinical pregnancy loss that probably relates to genetic factors and cannot be avoided. And so for all of these implantations, only a minority result in successful pregnancy. Our job is to try and figure out what the causes of these early losses are and correct it, especially in the setting of doing PGT and testing embryos, because we know that even with normal embryos that the pregnancy rate remains below 60% in most centers. So I'd like to talk about Beth because she's very germane to the case reports we've already heard about. And it talks about a woman with a very small 1 centimeter endometrioma who presented for infertility care. She was 34. She had 4 years of unexplained infertility, even though ultrasound eventually diagnosed a 1 centimeter endometrioma. She had a miscarriage with her first Clomid cycle and then went on to do IVF at her local IVF center in Washington, D.C. She failed a few times and then went out to Denver. By then her AMH was falling and she was unable to get a lot of eggs and was not successful. So she went to San Diego and got a donor egg. And she had 40 eggs from this donor, got 22 top blastocysts, and then failed, I think, 2 or 3 more cycles with those normal donor embryos. Now this woman had a small endometrioma, but it did not concern her doctors. She had already spent $100,000 at this point. The patient also had an AMH that was very low, and she had resorted to donor eggs. So operating on this endometrioma was really not going to harm her uterine or ovarian reserve. We did test her for the alpha V beta 3 protein, and she was missing it, and that is a sign of an endometrial receptivity defect. Based on that, and we saw no disadvantage doing this given her history, we did perform surgery, removed her endometrioma, and a little endometriotic implant. And then the next time she had 2 embryos transferred, she was successful with a twin pregnancy. The boys are now 5 or 6 years old and doing well, and she's had a little girl since then with another one of those donor eggs. This raises the question about whether endometriomas in fact cause IVF failure. We'll come back to that question in a minute. Other causes of implantation failure are shown here, and we know that before doing IVF, we need to establish that the endometrial cavity is normal. There are no polyps, fibroids, Asherman syndrome. We want to make sure there's not a septum or a hydrosalpinx present. So we know that embryo genetics influences IVF outcome, and this study by Sato shows that even for recurrent pregnancy loss or recurrent implantation failure, that checking the embryos is important, and it will improve your outcomes. The endometrial factors are also important. They can be influenced by polycystic ovarian syndrome, endometritis, hyperprolactinemia can lead to luteal phase defect, and endometriosis has really been lagging behind in terms of the general population's appreciation of its effects. One of the problems is that only 50% of women with endometriosis are infertile. And if only 50% are infertile, then when you do studies, you can always show that the patients don't seem to get pregnant, or they get pregnant, but you can never prove outcomes because of this 50% rule. And so it's been very difficult to establish with certainty that endometriosis causes implantation defects. Kurt Barnhart did a very important meta-analysis, but if you think about it, all of the patients in his study have already had surgery. And we know that surgery can improve IVF outcomes, it can improve fertility. So you're really not talking about patients with active endometriosis if you only study patients after surgery. You need to study them before surgery. So PCOS is an interesting subset of patients who seem to have implantation problems. If we look at this study by Dorr from 1980, a very old study, we see that hypothalamic patients in the upper bar, when they are stimulated to ovulate, are hyperfertile. They get pregnant at a much higher rate. One of the reasons they're so fertile is because they tend to not have endometriosis, having never menstruated. The middle line are normal patients trying to get pregnant, and the bottom line are PCOS patients. One can suggest that the PCOS patients in the lower curve may have endocrine problems that account for this, but we also reported that PCOS patients are much more likely to have endometriosis because of their heavy menses and the lack of progesterone. So endometriosis, does it affect IVF outcomes? The jury seems still out, and most doctors, like the doctors that took care of Beth, really don't consider endometriosis a great threat, even though in some patients it may actually be what's keeping them from getting pregnant. So we have been studying the endometrium of women with endometriosis, and we've come up with a model shown here. Normally, under the receptive or blue box, you can see that progesterone, when it's available, acts through progesterone receptors and turns on a series of transcriptions and genes that then allows normal decidualization. But most importantly, progesterone turns off estrogen signaling. In the right side, in the case of inflammation and endometriosis with IL-6, IL-8, IL-17, we have activation of KRAS. KRAS is turning on a protein called Sirt1 and another associated lymphoma proteins called BCL6. And these two proteins actively turn off the genes that progesterone is trying to turn on. And this leads to progesterone resistance. And importantly, estrogen is not downregulated and stromal decidualization does not occur. So progesterone resistance is a well-established consequence of endometriosis. We now believe that Sirt1 and BCL6 are the primary reasons why progesterone resistance occurs, and it's all driven by inflammation. So when we look at what it takes to implant, we know from this Wilcox paper in the New England Journal of Medicine that most women implant between LH6 and LH plus 10. But as you notice in this graph on the right, for every day after day 10 that embryos implant, the miscarriage rate goes up and up. This would suggest that there is a window of implantation and that moving this window has negative consequences. The paper by Wilcox suggested that these late occurring events were due to faulty embryos. I think that these late occurring embryos were coming into an endometrium that was simply not receptive because the corpus luteum could no longer be rescued after day 10 of the cycle. Further evidence that there's a window comes from this paper by Progesterone, showing that the days of progesterone exposure were also important for the success in IVF and implantation. You can see that day 2 and day 3 give fairly low success rates, but 4 days, 5 days, and maybe 6 days of progesterone were better. And arguing that there is a defined window of implantation based on progesterone exposure. Getting back to my inflammation slide and progesterone resistance, you can clearly imagine that if progesterone was not acting well, that these days of exposure for progesterone would be affected and endometrial quality defects would result. So synchrony is critical. Finally, endometriosis is biochemically very active. It makes VEGF, as shown here with the blood vessels that are occurring, but it also makes a lot of inflammatory cytokines, as outlined in Hassan's earlier talk. We know from experience that the endometrium can be biopsied in women with endometriosis and that clear differences can be ascertained. We showed that the integrins were different in these women, and Beth was an example of that. We recently published that BCL6 and Sirt1 are abnormal in women with endometriosis, and others have shown that nerve fibers are also predictive of the disease. So it's possible that the endometrium might be the key to finding out which patients are affected by their endometriosis and which ones need further treatment. For example, if Beth had had this test early on, perhaps her doctors would have been more keen to operate on her, especially in the setting where she had no ovarian reserve that would have compromised that decision. So we published in 2017 that women with elevated BCL6 had a very low pregnancy rate, as shown in panel C, compared to women who had normal BCL6 levels, as shown in A. And so BCL6 is one of many potential markers that could be used to try and figure out which patients require further treatment. And the treatments, we also published this in Journal of Assisted Reproduction and Genetics in 2019 in patients that had elevated BCL6 who underwent no treatment. The clinical pregnancy rate and live birth rate were very low, and the miscarriage rate was 50%. But if you took that group of patients and treated them either with surgery in orange or Lupron for 2 months, as shown in blue, we had equivalent success rates that approached 60% and live birth rates that approached 50%. And the miscarriage rate fell after treatment. Again, suggesting that designer targeted treatment of patients with known endometrial receptivity defects may in fact be a way of overcoming these problems. Finally, the new marker Sirt1 appears to be very promising because it can be detected in both the proliferative phase and the secretory phase. And as you can see in the Western blot and the immunohistochemistry, the Sirt1 and KRAS are both highly elevated in women with endometriosis compared to normal women without endometriosis. And we're going to show you some animal data to support the use of KRAS. So we know from animal studies way back from the 1980s and Bob Schenken that you can induce endometriosis and cause infertility. We took information about the rabbit model. We took peritoneal fluid from rabbits and injected them into other rabbits, and we could demonstrate that we could transfer their infertility in the peritoneal fluid. The baboon model has been used extensively to show that endometriosis causes infertility in the animal model. When we induce endometriosis in the baboon, as done with osgifoslavas, pre-inoculation, Sirt1 is low. 3 months, it's still low, but by 9 months and 15 months, you can see that Sirt1 expression is going up and up. And by 15 months, the inflammation is well established, and Sirt1 is a constant protein that's present. Sirt1 is, again, I remind you, a histone deacetylase that is actively turning off genes that progesterone is trying to turn on. Recently, in the mouse model, in collaboration with Jae-wook Jeong at MSU in Grand Rapids, he also showed that if you induce endometriosis, by the 3rd month, these mice are also making Sirt1 expression. You can see that more clearly here. We also can induce Sirt1 with a conditional knock-in mutant. So we can make the mice overexpress Sirt1, and those data are shown here in these 2 panels. When we overexpress Sirt1, an interesting phenomenon occurred. The mice with high Sirt1 got much more endometriosis than the mice with low Sirt1. And the number of implants were higher, suggesting that progesterone resistance itself is contributing to the disease progression. Further, and very excited, we found that the mouse who overexpresses Sirt1 either naturally in response to endometriosis induction or because of the conditional knock-in, both of those mice became infertile as a result of the elevated Sirt1. And if we give Sirt1 inhibitors, we can return those patients back to normal fertility. So treatment in humans has centered around things like norethindrone acetate, levonorgestrel IUD for people with pain, but for endometriosis, surgery or Lupron suppression. And one of the recent studies that, well, the advantages of surgery we've already talked about and I think is well established. It confirms the diagnosis and it may give a more permanent solution, whereas medical suppression is somewhat temporary. But this paper, which came out in July in Furt and Sturt by Steiner, showed that women treated with no treatment had live birth rates around 34%, with Lupron for 2 months, 36%. But if you gave Lupron plus Letrozole for 2 months, you had a much higher pregnancy rate, approaching 60%, suggesting that this is a problem that can be reversed by suppressing the endometriosis. And I think a lot of doctors in the US are now using the Receptiva DX test, and if the patients turn positive, are using this protocol before putting back frozen embryos. I would just add that we recently published in Human Reproduction Open that unexplained infertility and unexplained recurrent pregnancy loss seem to share the characteristic of endometriosis, that both groups have very high levels of BCL6. And when we laparoscoped the patients with unexplained recurrent pregnancy loss, most of them did have endometriosis, suggesting that these conditions are really very similar and perhaps are only differentiated by the degree to which their endometrial receptivity is compromised. As shown in this figure, if your endometrial receptivity window is wide open, you're fertile. If it's half closed, you have recurrent pregnancy loss because embryos can attach, but the corpus luteum isn't rescued. And if the window is completely closed, infertility results. So I hope I've given you something to think about today, that endometriosis doesn't affect everyone equally, and that having biomarkers of endometrial receptivity will probably be the way in the future that we can differentiate patients who need treatment and avoid IVF failure. Most importantly, we rule out structural, immune, endocrine, and infectious causes, but we recognize that endometriosis without endometriomas is often not evaluated because laparoscopy is less frequently performed. So again, the use of biomarkers could be very useful. Progesterone resistance appears to be caused by inflammation acting through KRAS, which induces SIRT1, and that SIRT1 is actively turning off progesterone genes. And I think new therapies directed in endometriosis based on this research are clearly possible. I'd like to thank my collaborators who did a lot of the work, and we have NIH funding with them, and I'll open it up for questions. Thank you.